right, folks, thank you for joining for our Rural EMS Education Series. I'm sure more people will trickle in, but to respect everyone's time, we'll go ahead and get started. I will let our presenters introduce themselves, but we're lucky to have some of our OB colleagues here tonight to talk about some OB emergencies. So I will let you guys take it away.
Great. Hi, everyone. Can everyone hear me okay? My name is Santi Paragas. I'm one of the fourth-year OBGYN residents at the University of Colorado. And I'll be joined by Cosette Kathawa, who is the current OB hospitalist fellow, also at the University of Colorado, and she's was my co-resident as well. She should be logging on here shortly.
Santi.
Hey.
Hey.
So we're going to be just running through some, from what I understand, the audience is mainly consistent of EMS personnel, paramedics, mainly. Is that accurate, Dr. Farkas?
Yep, you got it. And all folks who or mostly folks who generally practice in rural settings, so don't have the luxury of having a hospital with full capabilities 10 minutes down the road.
Right on. Well, sounds like an exciting job, and we'll try to do our best to orient the presentation towards those types of scenarios, understanding that some would be quite difficult to manage on your own with little experience, but we'll do our best. And throughout the talk, feel free to interrupt or throw questions on the chat. Either Cosette or I will be presenting, and then the other can just be monitoring the chat. And then at the end, we'll go over some case scenarios and leave it open for questions or stories that people want to share. So with that, I'll hand it over to Cosette, who will be going over the first few scenarios.
Perfect. And then we'd also love to hear your stories or things that have come up that you had questions about, or were wondering if they could have been managed differently. So feel free to chime in with any of those things too. So the first thing I'll be going through is just kind of your normal run-of-the-mill vaginal delivery, which, is not an emergency. Oh, the question is, will the session be recorded? I think it will be. Dr. Farkas, can you confirm?
Yep, all these sessions are recorded and they're all uploaded to the website. And I can put that link in there.
Awesome. Okay, so in terms of imminent delivery, so there are 3 stages of labor. The first stage is when your contractions start until your cervix is fully dilated. And then in that, we break it down into early labor, which is 0 to 5 centimeters, and then active labor, which is 6 to 10 centimeters. And then the second stage of labor is 10 centimeters of dilation until delivery. So basically when patients are pushing. And then third stage is delivery of the placenta, which for us, in terms of minimizing risk of hemorrhage, ideally happens within 30 minutes of delivery. And so I'm sure a lot of you have had this happen, but things to look for if you're suspecting that a patient's in the second stage is patients might feel the urge to push. So they might say like something's coming. If they are doing great and things are happening, then you might see the baby's head start to crown. If that happens, you can apply gentle counter pressure. Usually I use all my fingers on the baby's head just to kind of slow things down and prevent large perineal tears. Sometimes patients will be standing and that's not feasible, and that's okay. And then you'll see the head deliver. It should be followed by the shoulders. Sometimes you'll have to put some gentle downward traction on the baby's head to get that anterior shoulder out, and then the rest of the body usually follows pretty quickly. And then once baby's out, you'll dry them off and stimulate. Usually we wait a minute of delayed cord clamping to cut and clamp the cord. So you'll place 2 clamps and then cut in between. And then you can wrap the baby up and hand them over to mom to keep them warm. And then kind of take home message for a fast delivery like this is that it's really not an emergency. Most of the time, if things are happening this fast, that things are going to be fine and the baby's going to come out no problem.
Yeah.
All right, to you next slide. And then I just included like your APGAR score, just so once you get to the hospital, you can kind of report to the pediatric team who's going to be taking care of the baby, kind of what the baby looked like when they came out, just to kind of help direct their resuscitation if that's needed. In general, a baby that you're worried about is going to have an APGAR score of 0 to 3. A baby that's moderately depressed might need a little bit of extra support, will have a score of 4 to 6. And then a baby who looks great will usually be 7 to 10.
And so for you guys, as paramedics, we have a ton of experience doing exams to assess like at what stage the cervix is and if they're ready to push or not. And so I think for you guys, the main thing to be able to discern like en route or on the field is like, is the baby about to be born or is it not? And so that mainly means like if you go to do an exam, do you feel like the head right there? Or do you feel like tissue or like maybe like cervix is still there? And so if you can discern like, okay, this is a head, it's about to come out versus no, I might have some more time, just kind of you can triage what might come next, like if you need to do the delivery right there, or if you can, head out and go to the hospital right away. Um, and yeah, so most often you'll feed ahead, but we'll talk about a little bit later what else you might feel.
Perfect. So shoulder dystocia. Like I said, this is something that's going to happen more rarely for you guys because generally, if a baby is coming out super quickly, they're just going to come out and it's going to be fast and it's going to be fine. But a shoulder dystocia is when the shoulders don't deliver after delivery of the fetal head, even with gentle downward traction on the fetal head. In terms of risk factors or signs of an impending dystocia, so if the mom mentions that this baby feels huge or is larger than their prior baby, if they have a history of diabetes affecting their pregnancy, if they have a history of a prior shoulder dystocia, that's kind of the biggest risk factor. And then if while the head is delivering, you see turtling, so it kind of comes out and then retracts, comes out and then retracts. Or sometimes these babies will just deliver like up to their cheeks and then they'll just kind of be stuck there. Those are kind of signs of an impending shoulder dystocia. And then this is something that happens a lot, especially with our either a less experienced junior residents or with providers who don't do as many deliveries. Sometimes it's just a bed dystocia, and your bed is really what's getting in the way of those shoulders coming out. And so your first step, if you're suspecting a shoulder dystocia, should be to pull the patient down to the edge of whatever they're sitting on, whether they're in the ambulance, whether they're like on the couch at home. If they're like in their car and they're sitting on the side of their car, pull them down to the edge of whatever they're sitting on and then see if they can push again and if those shoulders will come out, because sometimes it's really just whatever they're sitting on that's blocking it.
And the reason this is an emergency is because like if the shoulder is unable to be delivered, then the blood supply gets cut off to the baby's brain. And so this is like one of the true like obstetric emergencies that we deal with on the labor and delivery unit. Uh, so
Yeah, this is something that shakes up even like your most experienced OB. So outside of the hospital, there are a few maneuvers that are kind of easy to do no matter where you are and what your experience is. So if you have a shoulder dystocia, so the shoulder is not coming out, you've tried doing gentle downward traction on the baby's head, it's still not coming. You should have the patient stop pushing. And then usually the first thing that we try is a combination of Mick Roberts maneuver and suprapubic pressure. And so there's a picture here where you can see they are really hyperflexing the hip towards the patient. And so you'll do that with both of their legs. And then the suprapubic pressure is pressure right above the, thanks for the pointers, right above the pubic bone. And that's to kind of push the baby's shoulder forward to try to get it under that pubic bone. And the important point here is that it's not fundal pressure, so it's not pressure on the top of the uterus, but it's really just pressure above their pubic symphysis or above their pubic bone to try to get that shoulder to kind of turn under that pubic bone. And so Once you've kind of got both of those things in place, you can have the patient try to push again and see if the shoulder will come. If not, another maneuver that I think would be pretty feasible to do in the field would be the Gaskin maneuver, which is basically having the patient on hands and knees, as you can see at the bottom. And here in this picture, they're kind of doing a rotational maneuver to try to get that baby out, but sometimes just changing their angle and having them go into hands and knees will be your next kind of thing that will help. And then we have other maneuvers that we'll often try in the hospital that I think are a little tougher if you don't have that experience. But if you can kind of try to rotate the shoulders, if neither of those things works, or try to get one of the arms out, that can often resolve the shoulder. I think there was a question in the chat.
I think the question was about a hard push versus doing it the suprapubic pressure constantly, or when the mom's pushing.
Gotcha. Yeah, so it's doing it constantly. So you're kind of like doing your McRoberts, pulling their legs all the way back, doing that suprapubic pressure, and then having the patient push while you're doing both of those things, if that answers the question.
Yeah. If things don't get answered, please speak up or use the chat, whatever. And then the other thing that we do often on the unit, if we're dealing with this emergency, is like having multiple providers attempt the same maneuvers. So if you're out there with a partner and need to switch, like someone might have smaller hands or can provide a different angle or better suprapubic pressure, like switching is something we routinely do on labor and delivery, especially since it's an emergency.
Yeah. And if you can, and if you have an extra person there, timing how long it takes to get the baby out is also helpful for determining outcomes and kind of updating your PEDS team. All right, and then cord prolapse is our next emergency. So this is another one that makes us move pretty fast on labor and delivery if it happens. And usually if we identify a cord prolapse, we are running the patient to the operating room emergently. And so basically what a cord prolapse is where the cord comes out in advance of the baby. So whether the baby's breech or head down, you can see that cord's kind of coming out in front of the baby. And the reason we care about this is because the presenting part of the fetus can put pressure on the cord and basically cut off their blood supply. And so this is really higher risk in like smaller babies, like preterm babies, or babies who are breech or transverse, where the like presenting part isn't well applied to the cervix and there's space for that cord to kind of slip through. Most of the time that it happens, it's with the water broken. Sometimes you can have like some cord in the bag if it's like a bulgy bag. And then the way you identify this is sometimes if it's a really extreme one, you'll see the cord kind of coming out of the vagina, which is a little more worrisome. Sometimes all you can feel is kind of like jelly cord kind of pulsating right in front of the baby's head or the baby's butt. And so you'll feel this pulsatile structure in front of whatever is coming out first. And so that's kind of your sign that they might have a cord prolapse. And so management in the field, I think probably the easiest thing to do is to have the patient go into a knee chest position, as you can see on the bottom, in that bottom picture, just to kind of get that pressure off the cord and try to preserve that blood flow. And then similar to when you're kind of putting counter pressure when a baby's head's coming out, you'll kind of place your hand in the vagina and elevate that presenting part off the cord to try to preserve blood flow. And usually I don't love these pictures, but I couldn't find a better one. But usually it's not just two fingers. That's just not going to be effective in terms of the force that you need to apply. So usually I'll go in, I have small hands, Santi can kind of chime in what he does. But I'll go in with my whole hand and kind of elevate the whole head or butt or whatever is there to try to ensure that that cord is still pulsing. And then the next thing is just to make sure your receiving hospital is aware that you have concern for a cord prolapse so that they can open an OR for emergency C-section. And then kind of the exception to all of this is if there's a cord there, but the baby is like coming out, just deliver the baby, and just have them push the baby out, because the goal is to get the baby out as quickly as possible, and whatever is the quickest way is the best way.
Yeah, I also try to insert my entire hand to elevate the presenting part. And if not, then if I can't, then I would just use the max number of fingers that would allow me to be able to do that. And then you just sit there and elevate it the whole ride until you get to the hospital. And that's what we do on L&D also. Like the person who does the exam and identifies it leaves their hand in until the baby's out. And so it's called riding the bed. So you ride the bed with the patient until you
Yeah.
get to the operating room and the baby's delivered, and then you can be done.
Yeah. So that might be you if this happens to you. So you might be the person who's like riding the bed all the way to the operating room, and then they'll like drape over you. They'll put all the surgical drapes up and drape over you. And then once you feel like the baby's out, or they'll tell you, then you can kind of climb out from under those drapes.
Yeah, it gets warm under there. Sorry.
I think we've all done it a couple times. Not
Yeah.
the most pleasant. Okay. And then I think this is probably one of the more common things that you all see apart from just your normal delivery. So postpartum hemorrhage. So definition of postpartum hemorrhage is over 1,000 milliliters of blood loss, or a liter, or delivery with hemodynamic instability. And so the most common etiology, you can see all of them kind of listed here. So uterine atony, retained placenta, lacerations, issues with coagulation. So we call them the 4Ts. But most commonly, it's going to be related to uterine atony, which is basically the uterus being unable to clamp down and kind of tamponade on its own bleeding, which should happen naturally once the placenta is out. So I think a common thing that we see when patients get transported after delivery via ambulance and we get called for concern for hemorrhage is that the placenta is still in place in the emergency room, which is very understandable. Most of the time, we live in Denver, so most of the time patients can get to us pretty quickly via ambulance. But definitely if you're farther from a hospital and the placenta is still in place and they're having ongoing bleeding, try to have the patient push out the placenta. So just have them push like the same way that they push their baby out. Or the other thing you can do is press on the top of the uterus or the fundus to try to express the placenta, and that's often a pretty hard push. And then what I would recommend is not trying to pull on the cord. I think if you've ever spent time with us on labor and delivery, you know that we put traction on the umbilical cord to deliver the placenta after a vaginal delivery in the hospital. But I think in the field, if it's not something that you are used to or kind of know the feel for, you just really increase your risk of a uterine inversion, or like tugging too hard in the uterus, kind of turning inside out, which is also a surgical emergency. So I would avoid pulling on the cord and just try to have the patient push it out, or try to give some fundal pressure to push it out. And then if patient's still having bleeding once the placenta's out, an easy thing to do that doesn't really require much in terms of resources is uterine massage. And I have a picture of that on the next slide that we'll show. But you're basically just kind of squeezing the top of the uterus and massaging it to try to get it to clamp down. And then my guess is that most of you all don't have access to uterotonics in your ambulances, but if you do, you can give Pitocin 10 units IM, and that can be given before or after the placenta delivers. And then after placental delivery, if you have them, you could give Methergin or Hemabate. Generally, if someone's very hypertensive, you should avoid Methergin, and if they have a history of bad asthma, you should avoid Hemabate.
Just to add to this slide, I think we often get calls from the ED for like outborn deliveries or imminent deliveries, and anticipating that this could be a potential problem that you experience in the field, or even like in the immediate pre-hospital setting when you're close to a hospital, is like to be ready in case this happens. So like establishing two large bore IVs and having fluids available, and then being active about like the things that will prevent postpartum hemorrhage. It's often easy to like focus the attention on the baby once the baby's born, which is absolutely also important. But just keep it in mind to make sure that you establish maternal stability as well. And I think this being probably the most common thing that you'll experience of all the emergencies that we take care of, if you can get as much done in the pre-hospital setting, that would be amazing. And I think the at the top of the list is just keeping them stable, making sure you have access, and then being active about the uterine massage and in being patient with the placenta. With
Yeah.
the question.
And then the other thing we hear people say a lot in the emergency room when we go down for these like outboard deliveries, is the placenta will still be in place, but people will be like, well, the fundus is firm, and they'll be like feeling the fundus. The most important thing is for it to be firm once the placenta is out. It's often gonna feel firm while the placenta is still in there because the placenta is kind of distending it.
Mhm.
Um, but usually if you can get that placenta out and that uterus clamped down, like that is going to be your best way to prevent a postpartum hemorrhage. So if you can have them push out their placenta or um, do some fundal massage to express it, that is going to be your best thing rather than just kind of having the uterus like failing to contract around that placenta and having continuous bleeding around it. And then someone asked about TXA.
Yeah.
It's a good question. TXA is a um, antifibrinolytic, and so it doesn't really help with uterine tone. I think if it's the only thing that you have and the placenta's out and you're doing all these other things and you don't have uterotonics, I think it's fine to give. But
Yeah,
it's not going to address like issues of uterine atony.
yeah, there was a trial that showed that it improved maternal mortality after an EVL of 1,000, but not as it didn't improve outcomes as a prophylactic measure. But if that's the only thing you have available and you're in the field and you're seeing bleeding, I don't think it's
Yeah.
wrong to give. In fact, I think it would be very proactive to give.
Mhm.
And I can, sorry, I switched out for Andra. This is
Yeah.
Angie,
Oh, hi,
Angie Wright from
Doctor.
the ED. Hey, so I think a lot of agencies have like a blood pressure cutoff for hemodynamic stability when they're going to be considering administering TXA. In the context of postpartum hemorrhage, I would think it'd be like a little more, it's much less straightforward than in trauma, which is like when the systolic is, less than 90 or your patient's hemodynamically unstable, you're giving TXA. Do you guys use a blood pressure cutoff typically, or would you say it's more about how much blood loss you're kind of estimating clinically?
Yeah, it's usually even if we suspect that the bleeding is related to atony and not like a coagulopathy, we usually give it around like a liter to 1,500 milliliters of blood loss, rather than using a blood pressure cutoff. But that's mostly because we have anesthesia at our disposal, and so usually they're treating the patient's hypotension, and so it's not always a reliable indicator. But it's a good question. I think for you guys where you don't have anesthesia, given like phenylephrine, it would be reasonable to give it for a soft pressure.
Yeah.
There.
I
Thank
mean,
you.
if you're like having vital sign derangements indicating shock, then
Yeah,
in the
give what
postpartum,
you have.
yeah, give it. I would give it.
Yeah.
Cool.
The hard thing
Thanks,
is a
Dr.
lot
Wright.
of our patients have like their normal blood pressure, systolic blood pressure is going to be 90. So usually I think more like systolics of like 60s, 70s for our patients in terms of worrying about hemodynamic stability.
Just as a poll, Dr. Wright and Dr. Farkas were telling us that Pitocin's not typically uh, carried
Okay.
in
Yeah.
the ambulances. Is that accurate for all? Or is there anybody in the audience that does have it or knows that they have it? Cool.
Yeah, if you guys want to throw like a thumbs up in the chat or something, it'd be really interesting to see. I know often we have people that log on from like Kansas and Nebraska as well. And so I don't know if they have different access to medications. Some of the uterotonics are in scope, but most of them, yeah, are going to be only the critical care. So a lot of our folks on can call for a helicopter or a critical care team to rendezvous if it's something that they think they need or if they're far away from the hospital.
Got it. Cool. Thank you. See any other questions regarding retained placenta? Is there anything we can do to assist with that hemorrhage? Well,
Yeah.
go ahead. Go ahead.
Oh, you go ahead, Santi. Curious
Well,
what
I
you're
was just gonna say, like, as far as like actually treating the problem of retained placenta, it's probably outside of the scope of pre-hospital medicine. But other than the things that we already talked about, like fundal massage or asking the patient to push, um, because you really want to avoid a cord avulsion because that can, you know, exacerbate the hemorrhage or a uterine inversion, which is like another emergency. And so beyond those things, just like being prepared for hemorrhage, would be all I could add or think of. I don't know if you want to add anything to that.
No, I think that sounds reasonable. I think the other thing to be aware of if the placenta is not coming out is one, is it just sitting in the cervix and it's like right there and you could just kind of like tug it out gently. I think that would be a reasonable thing to do because sometimes the cervix clamps down and it's just kind of sitting there.
Yeah.
But honestly, it would be a really hard thing to kind of parse out if you're not used to feeling for that. And then the other thing I think that's important to know and to kind of alert your receiving hospital is if the patient has a history of C-section, that it might be a morbidly adherent placenta and the patient might end up needing to go to the operating room. I think we're seeing more and more patients with a history of C-section laboring at home.
Yeah.
And so I think that's something we're going to start to see more often is like abnormally adherent placentas after home delivery.
Yeah, I agree. In fact, I had a case like that recently at the university where an outborn delivery patient had come in and the placenta was still in, and it had been like an hour. So like that's abnormal, you know, and so we like very gently tried to remove the placenta, thinking maybe it was like already partially delivered or completely delivered, but no, it was like a placenta accreta, which is like, you know, when it's adhered to the uterus, and she needed a hysterectomy and she had a like a 6 liter blood loss. And so, you know, more reason to not go for getting the placenta out yourself. Would the delivery
Yeah.
of partial placenta be a good indication of a retained placenta? Um, Most likely, like if you, what I'm trying to guess what your question is like if the placenta comes out and you see that there's like a section missing, yeah, I would alert the team when on arrival about that and the potential of a retained placenta or retained products as a reason that the patient might have ongoing bleeding. I, I hope that answers the question.
Yeah. And then the other thing, the reason that we're kind of talking about like don't pull on the cord. If you think the placenta is just like sitting in the cervix, you can like gently tease it out, but I wouldn't do anything too aggressive, is because sometimes you have worse bleeding if there's an accreta and you try to remove part of the placenta. And then two, sometimes if there is a little bit of retained placenta, like if part of it's removed but not all of it, that can also result in worse bleeding. And so I think it's just kind of massaging and getting them to the hospital as quickly as you can.
Yeah. And on L&D, our time cutoff for the placental delivery before we consider a manual extraction is 30 minutes. So let it sit in there, keep massaging, go to the hospital. Don't feel like as soon as the baby's out, the placenta needs to come out also. In the hospital, we give it 30 minutes, so you have at least that amount of time. This is just an image of how to do the massage.
Yeah. And so you'll have like one hand on the lower abdomen to kind of stabilize the uterus. And then you should be able to feel like a firm, kind of bump. Usually it's right around the belly button after delivery and after the placenta comes out. And so you'll kind of massage, sorry, I'm trying to do it so you can see. You'll kind of massage the top of that, and then you'll kind of be stabilizing the lower uterus with your bottom hand to kind of keep it from flopping around so you can get a decent grip on it. And it's not comfortable for patients, so if you have to give them something for pain, that is totally fine. This can be super, super uncomfortable for an unmedicated patient.
Cool.
Uh,
Any questions so far? Okay, great. Um, anything else you wanted to say, Cozy?
no, you're good. Go
Okay.
ahead.
So one of the common things that we see on L&D and that you'll also see in the pre-hospital setting is hypertensive disorders of pregnancy that come in a wide range. But I think the most common, like actual emergency scenarios that you'll see in the spectrum are related to the problems that occur related to preeclampsia, which comes in a few forms. Really, it's, preeclampsia without severe features, which typically is just blood pressure derangements with protein in the urine. But then the real emergencies start to come up with the preeclampsia with severe features, or eclampsia, or HELP syndrome. And so severe preeclampsia with severe features is the hypertension, typically over 160, over 110, with evidence of end organ dysfunction, which, on our end we see mainly manifesting as issues occurring in the lungs, the liver, the kidneys, and sometimes even the brain. Patients will have, and these are also quite a lot of the preeclampsia, and in the lungs, the thing that you might see more acutely is patients needing significant oxygen requirements as a result of pulmonary edema, or some evidence of severe liver dysfunction that you might be able to tell on exam. But otherwise, they're mainly lab derangements. Not obviously it's called preeclampsia because it's a precursor to eclampsia, which is all of the symptoms and manifestations that we've talked about, in addition to seizures. The seizures typically are tonic-clonic, and I'll describe them here shortly. But I just wrote here kind of what we think about with respect to the hypertensive disorders of pregnancy and what would mandate delivery at specific times. And as you see here, people that have severe preeclampsia, we deliver them pretty early at 34 weeks, or whenever they are diagnosed with a more severe eclampsia or HELP syndrome. HELP syndrome stands for hemolysis, elevated liver enzymes, and low platelets, which are all seen when taking blood tests, which we typically identify when they're in the hospital. But if they're like having seizures en route, then it's something definitely on the differential. Fetal manifestations of preeclampsia chronically are growth restriction, but these kids also often, as a result of being delivered preterm, have issues with dealing with the stress of labor, and so we'll see that on L&D often. So it sounds like you also are not able to administer antihypertensives in the field, but the biggest thing that we uh, worry about with preeclampsia with severe features is that it develops into eclampsia. And I do know that I think Dr. Farkas was telling us that you all do have magnesium sulfate, which is not used for the treatment of hypertension. It is solely as a treatment for seizure prophylaxis and for seizure treatment. And so if someone, 35 weeks has these severe range blood pressures, part of the first line treatment is to give them magnesium sulfate to prevent seizures. It does have the indirect effect as a smooth muscle relaxant as potentially lowering their blood pressures, but it's important to make that distinction that the magnesium sulfate is not a treatment for the antihypertensives from our perspective. It is solely to decrease the risk of seizure and to treat someone that is coming in with an eclamptic seizure. So does anyone carry antihypertensives? I guess probably the same as the Pitocin, I imagine. Cool. So yeah, so then I guess it would just be about alerting the team on arrival, like what the patient's blood pressures have been so that they can get them treated as soon as possible.
Yeah, and kind of like Santi mentioned in the prior slide, for us in pregnancy, anything over 140/90 is abnormal unless the patient has a history of like chronic hypertension. But the pressures that we really worry about are those 160s/110s because they just have such high risk of stroke and seizure with those. And so always helpful to mention the ones that are 140/90, but the ones we like they really need rapid treatment for is 160/110 because our patients can stroke pretty quickly, whereas like your normal like old man with chronic hypertension can be in like the 200s and not stroke.
And the conditions that we give magnesium for are these last three: the preeclampsia with severe features, eclampsia, and HELP syndrome. Everything else does not require magnesium. So if you're seeing these blood pressures, they're persistent, then it would be wise to give them the magnesium. Great. And so, like we talked about, the most severe manifestation of preeclampsia is its development into eclampsia, and is onset of seizures in a patient that has all the other signs and symptoms of preeclampsia and is not attributable to any other cause. For example, if someone has a history of epilepsy and their seizure characteristics are similar to previous, then it could be a result of untreated epilepsy or inadequately treated epilepsy. And so keep that in consideration, and taking a patient's medical history is important in that setting, because the treatment for that is not magnesium. It's to give them their anti-epileptics or Keppra, etc. Preeclampsia and gestational hypertension, super rare to occur before 20 weeks. So there, would be important to rule out any other reason for a seizure before 20 weeks. And typically the symptoms that manifest or can give you clues or warning signs that an eclamptic seizure might be imminent are really neurological symptoms, mainly worsening headaches, visual disturbances, blurry vision, double vision, like seeing lights in vision, or an altered sensorium. And so be mindful of those things and be prepared for a possible imminent seizure. And like we talked about, this is a medical emergency and requires immediate seizure control, and the treatment for that, like we talked about, first line is magnesium sulfate given at a 4 to 6 gram IV loading dose, followed by a 1 to 2 gram IV infusion. At the university, the loading dose we choose is 4, followed by a 2 gram per hour IV infusion, in addition to other emergency uh, treatments that you guys are complete ballers at, and keeping people stable and safe before they get to the hospital. I think one of the biggest things, ensuring that the patient has IV access to be able to receive that magnesium. However, if they don't have IV access, and I can put it here and send it to you guys, but if you have magnesium sulfate, it can be given IM as a 10-gram dose. So the way that we remember it is giving 5 grams on one butt cheek and 5 grams on the other butt cheek, for a total of a 10-gram dose. And
Yeah,
then
we tell our interns 5 and 5 and butt.
5 and 5 in the butt, IM. And so if they have recurrent seizures, can give another 2-gram bolus of magnesium sulfate, and if recurrent, can consider other agents like benzodiazepines.
And I'll just jump in.
Please.
For those of you that are on the Denver Metro EMS protocols, the IM magnesium is likely going to be coming soon, if not already implemented with the latest update. It's only been IV in the past, and we're trying to stay up to date with the latest guidelines and things like that. So hopefully that will be coming to everybody's protocol updates to be able to give it IM. And I think the question that I get a lot is like when to pull the trigger on benzos. So do you start with benzos? Do you start with mag? Do you just, if the patient is actively seizing and you don't know
Mag.
medical history, things like that,
Mhm.
what's kind of the proportion there?
Yeah. Without history, you have to, and they're pregnant, like term-ish, you gotta assume eclampsia, and the first line treatment is magnesium. So if they have IV access, give them what's written here, and if they don't, give them the 10 grams IM, and then I would consider benzos for second line agents.
And I will say, in my experience, eclamptic seizures generally stop on their own, and so they're usually pretty quick. And it's really rare for patients to go into like status with eclampsia. And so the MAG is really to prevent recurrent seizure, because usually by the time you're giving them anything, it's over. In my experience, like by the time we run to our postpartum floor, usually the seizure is like finishing or almost over. And so I think if the seizure is like not breaking after a minute or two, I would also give a benzo, if that makes sense. We had a patient recently, just to kind of tell a story, who was transferred to us. She was found down by her husband at home after having an unwitnessed seizure, and then was transported to another hospital, seized there again. And then once she was stabilized, got a C-section, and came to us intubated, was intubated for several days because she aspirated. And so I think we get really like tied up in like MAG, what are the doses and all of that stuff, but all of your normal seizure measures, like turning them on their side, doing all of that stuff is super, super important to prevent sequelae of the seizure, because usually that stuff is just as bad as the seizure itself. Which I'm sure the team did, but just something to remember.
Cool. Hopefully this never happens to you guys, but we'll talk about what to do in the event of a maternal cardiac arrest and some of the stats related to the epidemiology of cardiac arrests. Pretty rare. Some of the risks that um, have been identified are related to age, BMI, C-section, or vaginal delivery, and the potential like causes being more often than I thought related to anesthetic complications, meaning either like a high spinal or some other anesthetic complication that causes things like I actually had one who was in the setting of a postpartum hemorrhage, but during the induction of anesthesia for a DNC to help get the placenta out, that caused a profound hypotension and led to asystole. So that was a mixed picture, but and the anesthetic complications were a lot higher than I thought. Survival's higher than in the non-pregnant population. Um, and so the, diagnosed the same way, treated the same way, with the exception of a deviation of the uterus. They can still remain in the supine position, but someone should deviate the uterus to the patient's left so that it allows for a more adequate, venous return and improved cardiac output. But the rest of the ACLS protocol should remain the same. From our perspective, the only additional treatment that is required for someone who is gravid above 20 weeks in the setting of a cardiac arrest is to perform a perimortem cesarean for maternal benefit. It's, I think colloquially learned that the perimortem C-section is to like save the baby, but it's not. It's solely to save the mom. So I want you all to remember that specifically. The reason to get the baby out is so that the blood flow that was previously provided to the gravid uterus is now being provided to the maternal vital organs. Um, Obviously, the baby is going to go to the NICU team and is going to get resuscitated as well, but the reason that it's performed is for solely maternal benefit. Often you won't really know. Like you might have a brief history that the patient's pregnant, but you don't know how far along or like what's going on. And one of the quick things that you can do in the field is just palpating the top of the uterus, and typically at the level of the umbilicus is about 20 weeks. And so if you're at least that, then you will get benefit of a perimortem cesarean for maternal benefit. Something that we can do when the patient arrives is just drop a quick ultrasound and kind of do a quick measurement of the gestational age, but really it's like exam and just like confirm there's a baby in there and then do it. And the reason you have to move so fast is because it improves maternal outcomes and survival. And it's so fast that you should be basically getting the table set up as the patient's arriving or already be ready in the trauma bay, if you know, were aware that they were coming in. And so by 4 minutes, you should be starting the C-section, and the delivery should be done by 5 minutes. And ACLS is continued throughout this entire process. Like we talked about before, the reason that we do it is because of the massive maternal autotransfusion that occurs when uh, there's no longer a need to supply blood flow to the gravid uterus, and then that returns a significant amount of cardiac output to the maternal vital organs. And so these slides just really show that in just graphical form, how like the patient's like maternal vital signs and cardiac output are improved after the delivery of the fetus, and the folks that did them faster had better outcomes. It's important to do the procedure where the arrest was identified. This graph shows the proportion of people that died versus survived based on where the procedure was performed. And it basically says that if the patient arrested in the ED, then you're doing the perimortem C-section in the ED. You're not transferring them to L&D to do it in the operating room. That wastes vital seconds of time to do a life-saving procedure. Whether it's I've had to do one in the ICU, in the ED. So wherever they're at, they should be coming to you, not you to them.
And generally, all we really need to do the perimortem C-section is just a scalpel, because the patients aren't going to bleed until they get ROSC. And so usually all we need is a scalpel. We'll just kind of go down bluntly through most of the layers, and then we'll just whip stitch the uterus closed and pack them until they're stabilized and can go to an OR to kind of finish up the surgery.
Exactly. And the only other thing I'll add to that is that you got to think about like what could have caught from our end, like what could have caused her to have this arrest. And sometimes it's a result of like severe intra-abdominal bleeding, or if they were in a MVC, they have a liver lac or a splenic lac or something not related to an obstetric problem. And so the way to be able to be smart about the surgery is to make a vertical midline incision and deliver the baby as fast as possible, like Cosette was saying, and then the placenta can stay in, close the uterus, and then pack the area until you can get to an OR where you can more safely identify what the problem is. Or even there, like if you have trauma surgery on board, they can identify other areas that might be injured. Often I've had a case that needed a splenectomy and also had a liver lac, and so you need to run the bowel. And so if you make a fan and steel incision, you're never going to be able to do those procedures, and the patient ends up with a T incision, which is a lot harder to heal from. But in that setting, the patient's dead. So 2 incisions, just do what you need to do. But if you're smart and think about it prior, then you're making a midline vertical incision. And I think our ED providers are also taught this way. And I haven't met any ED resident that has needed to do this before or they were attending, but it sounds pretty badass if they have that as a story to tell.
Ian was just asking how perimortem C-section applies to pre-hospital providers. I think the reason we included this was mostly just to make sure that you're alerting whoever is at the receiving hospital, whether it's an ED provider or an OB, that you have a patient that they've been coding for whatever, 4 minutes longer, and that you need somebody available to do that perimortem C-section once you arrive.
And
Yeah.
so I know best done within 4 minutes of arrest. One of the things that our pre-hospital providers face, and Ian, I think this might help with your question too, is, they do have protocols often to terminate resuscitative efforts in the field if it's been X amount of rounds, if an end tidal is a certain number, if they've given a certain amount of epi. And I know this is an absolutely impossible question. My emergency medicine and EMS doctor self would say you're transporting these patients no matter what, and then probably letting the ER and the OBs decide whether the surgery is indicated and whether there's a chance at that point, even if it's been 10, 15, 20 minutes, especially if ROSC is intermittently achieved. I think, Ian, to your question, having a different threshold, knowing that this is at the other end of your transport, I think is a really important takeaway for this. To kind of be able to, and from our super rural folks that have a doctor in a fly car that can potentially get out to where you are. I know it's very uncommon, but it would be more common than a field amputation or something like that. Another thing to kind of think about with these. I've never done one. I was only there when they did one and then realized that the patient was not in fact pregnant, which is a legendary case.
Yeah.
And not ideal.
That was when I was an intern.
I remember that case too.
Yeah, thanks, Dr. Wright. That's super helpful.
And there was a question, and I apologize if you guys touched on it or not, but on the mechanical CPR devices like the Lucas and things like that. I don't know if you guys have a opinion or any literature in your world about those, and whether you're pro or against. Like, for example, trauma hates them. But sometimes it's only the only practical option for some of our providers. But I don't know what your guys' thoughts are there.
There's not any data that I know about in the obstetric literature. I don't know if Santi came across anything.
Yeah, I'm not aware either. I can ask Dr. Hirschberg, who is one of our MFM critical care doctors, to see if he has any insights. Could get back to you, but not that I'm aware of. I've never seen it used in the obstetric population.
Sounds
Or heard
good.
of.
I mean, the literature in pre-hospital and the ER also is lacking. So I would not be surprised if it was lacking there too. There's just a side question. Thank you guys. Thank you.
Cool. Well, we have some those are the emergencies that we had for our field. We have some cases that we can run through if you would like, would require some more participation. So if you guys are into it, or if you have any questions about what we've covered so far. And some of the cases will have examples that we already covered, and some will have like others that we haven't. Cool.
Let's do it. I like cases. I'll participate.
Okay, sounds good.
I'm learning.
So our first case is of a 30-year-old G2P1 who is reporting symptoms of labor and is in the backseat of a car. And when you arrive, you see that the baby's crowning. And so
Just really quick for
yeah, go ahead.
P1. So the way we talk about like how many pregnancies people have had is gravida and para. So this patient has had 2 pregnancies and had 1 baby previously, but is currently pregnant, is what that means.
And so I would love to just kind of hear from your end, kind of how you would think about your approach to taking care of this patient. If anyone wants to be brave. I mean, you guys are EMS workers. Of course you're brave.
Yeah, braver than us. Deliver the baby. True.
For the baby. Okay, great. Can you give
I was
us
gonna call on you, Kaylee.
since
so.
you
I'm
since
glad
you
you spoke
volunteered,
up.
Kaylee, would you be so brave as to tell us how you would approach delivering the baby?
Yeah, so I guess it depends on like how far out the baby is, but if she's just crowning, then you could start with that like slight pressure on the baby's head, just kind of go with her natural pushing and whatever sort of contractions that she's having. And then just kind of go through the motions essentially. Like once the head's delivered, slight downward pressure, shoulders delivered, get the baby out. Hopefully
Totally.
that's how it goes.
Totally. Um, yeah, that sounds great. Prepare for an immediate delivery, control the delivery of the head, suction stimulate the neonate, clamp and cut the cord, and then monitor for postpartum hemorrhage and then transport. I don't know what y'all's protocols are, but like if someone is like visibly crowning on arrival, to me, it makes more sense to like use the training that you have to like do the delivery right there because it's like imminent. But is there like specific protocols for you all to like for this scenario to be like, nope, no matter what, we're leaving and we can do it like on the way, or just doing it right there?
I mean, well, for me personally, I wouldn't be moving. There's imminent delivery, so
Yeah,
a we're just wasting time, and realistically this mama's gonna push this baby out by the time I get her moved over to the stretcher anyway, probably.
true.
So it's not worth it to me to try to transport her while she's delivering. Also, it could create a pretty unsafe environment, just my personal opinion, because it would mean that I'm unrestrained. My patient is likely also unrestrained, and now I have a third patient entering the world also unrestrained, and it can get pretty scary, I think.
Yeah, totally.
Sounds great. Cool. Thanks, Kaylee. That was wonderful.
Yeah. And
Well
Eric
work.
said, last thing I want to do is deliver an ambulance en route.
Right side pedal fully depressed. That's great.
And then I didn't talk about this when I was talking about delivery, but I think a lot is made about nuchal cords, and people are like, my baby was born with a cord around their neck. It's actually really common. It's like somewhere around like 30% of deliveries have a nuchal cord. And most of the time it's fine. If it's like easily reducible and you can kind of loop it around the baby's head, once that head is out, you can. Most babies will just deliver through it and then you can just kind of unwrap it once they're out. Very rarely is there like such a tight nuchal that that it's limiting delivery. Um, so just something to, I think a lot is said about it, but honestly, don't worry too much about it.
The other thing
Uh,
I'll note for this case is, and for really any second or third time mom, like previous vaginal births, their second stage, meaning like 10 centimeters to like getting the baby out, happens a lot more quickly than someone who's a first time mom, like a G1. And so just consider that you might have more time in those G1s than in the G2, G3s that are completely dilated. Sometimes we push with people that are G1s for like 4 hours. So just keep that in mind as far as when you see someone like, hey, have you had other babies before? Yes. Okay, let's get ready now. No. And then, the head's not out yet, but they're really uncomfortable. You might have more time than you think.
yeah. And if someone's had a baby before, vaginally and they're crowning, like don't turn your back on them because that's when
Hmm.
babies fall on the ground. Sometimes they just need like one push and that baby's out. So just like keep your eyes on it and keep a hand ready to like catch the baby's head as it comes out because sometimes they kind of fly out.
Cool. Thanks, Kaylee. That was great. Do you want to popcorn it to someone for the next case? Is there someone that you know that you want to volunteer? Volunteer?
Uh, I think I saw Daria Nikki, if she's listening. I think Daria's in here.
Daria, are you down for the next case? And we'll help you.
Daria's left the chat.
Daria unsubscribed. Okay. So we talked about this type of patient before, but G3P2, 28-year-old, you are in the field in the same scenario that you were in before, but instead of the whole baby coming out, only the head delivers and retracts. And does anyone remember what this problem is called?
shoulder dystocia.
Nailed it, Deborah. Thank you. Okay, and so, like we talked about, this is a surgical emergency. Deborah, do you remember, or excuse me, yeah, an obstetric emergency. Deborah, do you remember kind of what we talked about as far as the management of this scenario?
You can try gentle downward traction, changing the position of the woman to the edge of the bed or on hands and knees.
Nice. Excellent. Yeah, the only additional maneuvers that you can try is the McRoberts maneuver, which is, like you said, changing the position with the legs at the hip hyperflexed and against the abdomen. And typically it requires a couple people to do this. And then suprapubic pressure, meaning pressure literally straight down just above the pubic bone, not pressure up above by the fundus, like by the belly button. That's fundal pressure. That's what we talked about, like getting the placenta out. This is different. This is suprapubic pressure with the main goal to get to deliver that anterior shoulder. Like you said, Gaskin's maneuver, it's putting the patient on the hands and knees, and then if unsuccessful, truly getting to the nearest hospital as fast as possible, because seconds matter in this with this problem.
And
Deborah, go ahead.
I was just gonna say, if the baby is truly not coming with those maneuvers and you are more than a few minutes from a hospital, just start doing things and have your partner start doing things. So try to turn the baby's shoulders inside the vagina, try to pull an arm out. If you break an arm, it's okay. Sometimes that happens and it'll heal fine. But like whatever you can do to protect that baby's brain. But hopefully for you guys, most of these babies are just flying out. And if not, these things will get them out.
Thanks, Deborah. Deborah, do you have anyone that you know in the chat that you want to send it to?
I'm sorry, say that again.
Do you know anyone in the chat that you want to volunteer to help us with the next case?
Oh, sure, Cassandra.
Cassandra. Thank you. Thank you, Deborah. Okay, so this is a completely new clinical scenario, but so I'll take it easy on you for this one. But you have a 36-year-old G4P3. You're called, again, similar scenario, but instead of seeing that a head is coming out, you see a butt is coming out. And so this is what we see sometimes, although quite rare, and if identified early, would be of consideration for doing a C-section versus a vaginal birth, but this can also be done. But the main differences are for this scenario are that you should be patient. The main problem that we encounter when taking care of folks that are having a breech vaginal delivery is the possibility of a head entrapment, meaning that, typically the head is the widest part of the body that is able to help fully dilate the cervix, but if they're coming down breech, that might not be able to be accomplished. And so if the cervix isn't adequately dilated to be able to let the head pass through, then the butt or the legs come through, and then the head gets stuck kind of in the reverse fashion that we talked about with the shoulder dystocia. And so, go ahead.
I was just gonna say, we particularly worry about that risk of head entrapment with preterm babies because usually the head grows a lot faster than the body. And so they have these little bodies that slip through the cervix, and then the head kind of is too big to slip through. And so something to think about.
Cool. And so, forgive me. The main thing to do in this setting is really to be patient and try to let the baby deliver itself for the most part. Really to the level of the umbilicus or even to the level of the scapula. And then what will get left behind are the arms and the head. And so while supporting the baby's body, the way to deliver the arms, and I'll show a picture here in the next slide, you'll kind of swing around and kind of loop your finger around the baby's arm
Kind of like
and
pulling it out like this.
yeah, it's It's better to use a picture, so I'll get to that. It's called a love set maneuver, but you essentially kind of wiggle the arms out and then you flex the head with your hands to be able to deliver the head at the end. Sometimes moms just push babies out and you don't even need to do anything, which I hope is what happens to you all if you ever are in this scenario. But these are just some of the maneuvers that we routinely practice and obviously ensure prompt neonatal assessment if resuscitation is needed. And so here, and you guys should have access to these slides and presentation, but you'll see that sometimes you'll need to assist the delivery of the legs, although often I feel like this is much easier and doesn't require very much active management as long as the patient's like providing adequate expulsive efforts. And then like you see here, you can kind of turn the baby so that the shoulder, the arm you're working on is facing up. And then you go in with your fingers, kind of loop in at this joint here and bring the arm out. And then you twist the baby the other way and then do the same maneuver. And then while someone is providing that suprapubic pressure with both hands, you're flexing the head here and then allowing for the delivery of the fetal head.
And the reason that we don't want anyone to pull on babies is because the goal is to keep the head flexed, which is what that like more so smelly bites maneuver does, is you're kind of pressing on their cheekbones or like in their mouth to flex the head. But if you pull on them, it often can like extend their head, and that just creates like a bigger diameter that needs to come out and increases your risk of head entrapment.
So I'm kind of glad that you guys answered this one so I didn't have to, but what's the time frame on these deliveries in, especially if you're saying the delivery is underway, so the baby is going to be coming out probably before like our minimum 30-minute transport, but compared to a regular vaginal delivery, how much time do you have most likely?
So
Yeah.
for it depends, I think. You know, if you have a multiparous patient or someone that's had babies before, this probably all of this probably happens in the realm of a few minutes, maybe like 2 to 10 minutes. In someone that's a first timer, I've had them like pushing with like part of the baby out for around like 20 minutes. And so the, you know, and the tenets are the same, to be patient, to let the mom push to the level of the umbilicus and scapula and then work on the additional maneuvers. But for a first timer, it can take significantly longer.
Yeah, ideally, like once the bottom is out and you can see the cord, that's when things need to move a lot faster, just because that cord gets exposed to cold air and can vasospasm. And so it's really like the shoulders and the head that we tend to try to expedite, but that it can take a while for like a bottom to come out.
Thank you.
And then often you'll see this too with like a second twin, and those are the ones that we often will like when you have an OB in the hospital, they'll like pull down to try to have them come down that way. And so those ones we do pull on. But if it's a singleton and it's just coming down breech, try to leave it alone as much as you can, unless you're concerned that that head's not coming out.
Okay. Also not one we covered, but it's something that I hope people know about or have seen. And so I can go through this one as well. But 32 years old, G2P1, she's at 34 weeks, and you're called, and the patient is complaining of pretty severe abdominal pain and is having pretty significant vaginal bleeding, more than what you would expect for someone in labor. And her abdomen's rigid and her vital signs are notable for hemodynamic instability. Main things to be seen would be things like tachycardia, hypotension. Let's see. I like it. Someone said uterine rupture. I think definitely on the differential. This patient has had one prior vaginal birth. I'll note that. Uterine rupture, I think more about in people that have had history of C-section, which the next case actually goes over
John, you're
that
ready.
scenario. Um, but um, but this is a case about, let's see, nice.
Deborah got it.
Deborah killed it. So yeah, so these are classic signs for placental abruption, mainly, uh, contraction, significant vaginal bleeding to the point that it's causing hemodynamic instability. Often this is accompanied with labor. The body basically recognizes that the placenta is abrupting and triggers a labor response, cervical dilation, and can be accompanied with not only labor, but a preterm birth. And so for you all, after that's been identified, basically taking care of someone who is in hemorrhagic shock is the same way that you treat this scenario, in addition to the possibility of also being prepared for an imminent birth. And so, the same tenets of how you all treat hemorrhagic shock. You don't need me to explain that to you. You guys are pros at that. But basically, prepare and treat that, and alert the staff and the team when you arrive of the situation, which, if the baby's not yet delivered and the patient's so unstable, would require like an emergency surgery, or if like ready to have a vaginal birth, could try for that. But typically,
And
if they're this sick, then delivery is needed emergently.
And I know like some of the critical care folks or the life flight folks might have like TOCO or contraction monitoring. And so you might see kind of like frequent contractions on your TOCO, and that might also alert you to the possibility that you have an abruption because that blood is just irritating the uterus.
Yeah, so cool. Way to go, Deborah. Okay, next, who said uterine rupture? This is basically that. It's basically a very similar scenario as far as signs and symptoms, but is typically seen in patients with a history of a C-section. Although a spontaneous uterine rupture is also possible, but exceedingly rare, but definitely more common in people that have had C-sections in the past. The main signs and symptoms, severe abdominal pain, vaginal bleeding, um, and then an abdominal exam can sometimes palpate fetal parts, but sometimes that's hard to discern, especially for someone that's not used to, doing those types of exam. But basically, signs of hemorrhagic shock in the setting of a history of a C-section with significant, vaginal bleeding, that should be very high on the differential. And the key actions to take are basically the same as the placental abruption, basically treating the shock and then transporting as soon as possible for an emergency C-section, noting that a uterine rupture can lead to significant hemodynamic instability and arrest. And so the possibility of a perimortem C-section is definitely real. And then I think I had yeah, here's just a picture of what we see when we do the procedure. Basically, when we get through the fascia, you see like fetal parts in the abdomen and complete dehiscence, rupture of the previous uterine scar. Although, like I said, a spontaneous rupture is possible, but exceedingly rare. And so sometimes, you might see vaginal bleeding on exam, but this can also be completely intra-abdominal, from a laceration to the uterine artery, and that's causing like a retroperitoneal hematoma or just strict intra-abdominal bleeding. So you might not see like visible blood, but it'll all be in their abdomen. So
And patients often note pain along their prior C-section incision, which is different than contraction pain, and that's also something to kind of take note of.
cool. Any questions? I think I have one or two more. Oh yeah, here we go. This is another, maybe someone has seen this before, but 40-year-old G3P2 just had a baby, and en route becomes hypotensive, cyanotic, and unresponsive. Anyone have any ideas of why someone might develop this postpartum? no significant vaginal bleeding, was okay prior, but very suddenly developed these things. So, oh, yep, here we go. What do we got? Nice. Yep. Oh, this is a good one. Yeah, exactly right. An amniotic fluid embolism is, also a very rare event, but another obstetric emergency that we see. And what is seen is, a very sudden change in status, namely uh, sequelae of what an amniotic fluid embolism causes in the body, which is essentially like an acute anaphylactic-like reaction, but patients will get hypoxemic, hypotensive, and very quickly decompensate and often require ACLS. And so if that is, seen, then get ready to do ACLS. So yeah, I mean that's really all you can do at that point, and just supportive care through ACLS and oxygen fluids, and get to the ER as soon as possible and start coding them if needed. But there's no like other acute treatment to do in the pre-hospital setting. That was great, Deborah, coming in hot. Good work, everyone. I think that's, yeah, I just have here a pictorial representation of like what that is basically. It can happen, it's more rare like intrapartum, but like during the delivery or immediately postpartum, it can happen. And so just be mindful of that as a potential problem that you might see. I think that's all I have for the cases. But if anyone has any questions, concerns, I believe this is the QR code to get credit for the continuing medical education. But thank you so much for having us. I hope we